Definition and clinical significance, diagnostic criteria, types of Wellens syndrome, pathophysiology, differential diagnosis, ECG examples, and lastly, the winter T waves vs Wellens syndrome. So first of all, definition. Occlusion it means a blockage of the arteries, while stenosis it means a narrowing of the coronary arteries, since we are talking about the heart. Generally, it develops because of atherosclerosis, and in the case of an acute progression of a stenosis, the patient either will have unstable angina or an anstemy, which is an infarction. In the case of unstable angina pectoris, there is no myocardial necrosis occurring, which means that there is no troponin release, while for the anstemy infarction, the troponin will be released because the myocardial necrosis occurs. Wellens syndrome is defined as a critical proximal stenosis of LAD, as you can see in the picture on the right, or it's called also intraventricular artery. Usually the patients they develop anterior STEMI within about 1 week after the Wellens syndrome pattern on ECG, and it's about 75% of patients. On the ECG, it shows an atypical T waves which is present mainly in lead V2 and V3, but it can be also present from lead V1 till V6, but usually it's in these two leads. And it's present in about 15% of patients with unstable angina pectoris. If we have such patients, they should not undergo ergometry. It's called also stress testing, because during ergometry, the patient could experience an infarction. That's why we should send them immediately to coronarography so that we can put a stent in the proximal LAD. We have to keep in mind that this pattern is usually present in the pain-free state, which it may be obscured during episodes of ischemic chest pain when there is a pseudonormalization of T waves in V2 and V3. Wellens syndrome remains a key example of why all patients presenting with chest pain must have serial ECGs. So patients who have a critical proximal LAD stenosis, they are asymptomatic, and in their history they will have angina pectoris. These patients are the patients who have Wellens syndrome on ECG. So these changes, there will be rarely seen, as I said, rarely seen in leads from V1 till V6, so mainly we will see them from V2 till V3. We won't see any precordial Q waves, there will be preserved precordial R wave progression, and there will be a normal or slightly elevated serum cardiac markers. There are two types of Wellens syndrome. We have type 1 and type 2, though in some materials or in some sites you may find that it's referred to as type B or type A. Anyway, for type 1, it's more common form, about 75% of cases, and it's shown as asymmetrical, deep negative T waves, which is descending almost vertically downwards. While for type 2, it's a less common form with about 25% of cases, also known as type A. It's presented as biphasic T waves when the first part is positive and the second one is negative. There will be also a ST elevation, which is present up to 2 millimeters in the precordial leads. And both types of Wellens syndrome can alternate in a single patient. Here we see a picture showing type 1 of a Wellens syndrome with asymmetrically deep negative T waves in V2 and V3. Here we see an example of type 2 Wellens syndrome, where we consider it's biphasic T waves in V2 and V3. The first part is positive and the second part is negative, and also we can see a minimal ST elevation, but it's still about 1 millimeter. It's not more than 1 millimeter or 2 millimeters. Here we see the evolution of T waves over time from biphasic symmetrically T-wave inversion. Here we have an example of an angiography of a patient who was subjectively asymptomatic and only experienced recurrent chest pain at home. We can see that the coronary angiography has revealed that there is a 95% stenosis of the proximal LAD. And here in the other picture, we can see that it's completely recanalized after putting a stent. And of course, there will be here a physiological ECG after putting the stent. And this sign on the angiography of proximal stenosis or occlusion of LAD is referred to as the widowmaker artery. Widowmaker artery. Now let's try to understand the sequence of events which is occurring in patients with Wellens syndrome. So first of all, there will be a sudden complete occlusion of LAD, which causes a transient anterior STEMI, and it causes chest pain and diaphoresis. This stage may not be successfully captured on ECG recording. After that, there will be a reperfusion of the LAD, either due to spontaneous clot lysis or the patient, for example, had some aspirin, which will lead to resolution of chest pain, and ST elevation which will improve. With T waves, they will become either biphasic or inverted, which is the Wellens pattern on ECG. The T wave morphology is identical to patients who reperfuse after a successful PCI. Now, if the artery remains open, the T wave evolve over time from biphasic to deeply inverted, as I showed you before. And the coronary perfusion is unfortunately unstable, and the LAD can re-occlude at any time. If this happens, the first sign on ECG is an apparent normalization of the T waves. It's called pseudo-normalization. The T waves switch from biphasic or inverted to upright and prominent, which is a sign of hyperacute STEMI, and it's usually accompanied by recurrence of a chest pain, although the ECG changes can precede the symptoms. Now, if the artery remains occluded, of course the patient develops an evolving anterior STEMI. Alternatively, a stuttering pattern may develop with intermittent reperfusion and reocclusion. This would manifest as alternating ECGs demonstrating Wellens and pseudonormalization or STEMI patterns. This sequence of events is not limited only to the anterior leads, but similar changes can be seen also in lateral or inferior leads, For example, with circumflex occlusion or right coronary artery occlusion. Also, the inciting event doesn't necessarily have to be thrombus formation. It can also occur because of a vasospasm in a normal coronary arteries, as in the case of a cocaine-induced vasospasm. However, it is always safer to assume the worst, which is a critical LAD stenosis, and work the patient up for an angiogram. So for differential diagnosis of Wellens syndrome, we have a lot of cases with a similar pattern of negative T waves, but of course the previously mentioned features, they will be only for Wellens syndrome. For example, we have pulmonary embolism, right bundle branch block, right ventricular hypertrophy, left ventricular hypertrophy, hypertrophic cardiomyopathy, intracranial hypertension, persistent juvenile T waves, Brugada syndrome, hypokalemia, and in physiological EKG in children. Now let's see some examples. Here we can see the pattern of a Wellens syndrome with the biphasic T waves where it's positive. The first one is positive and the second part is negative. We can see it in V1, in V2, V3, and also in V4. We can see also slightly elevated ST segments, about 2 millimeters. The second example is with deeply negative or symmetrically negative T waves. We can see it's elite V1, elite V2, V3, V4, V5, and V6 in all the precordial leads. And we can see that there is a slightly elevated ST segment. Mainly here we can see it in V4, but it's just about 1 millimeter. Now let's have a look at an interesting example. So here we have also, it may look like it's a Wellens pattern, but actually if we look closely, we have other features. If you calculate here, the heart rate is about 100, and we consider it's a right axis deviation. We have also a feature here, if you notice that there is a clockwise rotation. If you notice from V5 till V6, there is R wave progression is reversed. And we have also in lead 3 a slightly negative T waves. And usually all of these signs are specific for pulmonary embolism. So this one is not actually Wellens syndrome, but it's a pulmonary embolism example. Let's have another look of another ECG. Here also we have a prominent, as you can see here, a prominent T waves. As I mentioned before, it can be a pseudo-normalization of the Wellens syndrome, but actually it's not due to Wellens. As you can notice here, we have a criteria of left ventricular hypertrophy. We can see V6, if you calculate V6 plus the R wave, I mean in V6 plus S wave in V1, it's more than 35 millimeters, which is diagnostic criteria for left ventricular hypertrophy, and this pseudo-normalization pattern is due to left ventricular hypertrophy, which is one of the main also differential diagnosis patterns of Wellens syndrome. Now let's talk about the winter T waves. The winter T waves, it refers to a proximal LAD occlusion, and the patients here will have angina, and it's considered of course as equivalent of STEMI. So on ECG we will see changes in V1 till V6, we will see symmetrical high T waves and ascending ST depressions. Here we have an example of the winter T waves. You can see ascending T wave depression. We can see also the prominently elevated T waves in all the precordial leads. One other feature here that suggests that it's a STEMI, it's in the AVR. We see that it's elevated, more than 2 millimeters elevated in AVR for the SC segment. You also see some changes in lead 1, in lead 3 as well. That's all for today. Thank you for watching. I hope it was useful.